Action. Hi, everybody. And here I'm again, Agam Vora, with one more ECME under the auspices of Chest Council of India. And we are going to be talking about one immunomodulator that is very close to my heart, and that's Sepsivac, Mycobacterium W. I must thank NH Krishna, for giving me this opportunity to be here with all of you today. Krishna is my close friend now for more than 5 years, 5-6 saal, I think 6 years now. Just a casual exchange of WhatsApp messages, it has grown into a thick friendship, and he cleared my lot of myths. I was thinking that places does matter. मैं बम्बई का लड़का तो अपने को लगता है places do matter. I was of the opinion that qualification does matter. Krishna proved that you do not need 5-star attachments. You do not have to be a professor and head of department anywhere. You do not need to be a director of any institute. You just need one strong commitment. You just need one strong desire. One must have courage to dream and live that dream. And वो शाहरुख खान की स्टाइल में बोलते हैं ना भूषण कि अगर इरादे नेक और whatever पूरी कायनात जुड़ जाती है, and that is what happened with Krishna. Krishna, thanks for your years of hard work and thanks for giving us this platform. When I think about Sepsivac, I think of my teacher, Professor Director Dr. K.C. Mohanty. My guide, he started using this somewhere way back in the year, if I'm not mistaken, it was 2002, 2003, in the management of tuberculosis, especially drug-resistant tuberculosis. And then Sepsivac saw a few ups and downs, but with this use in gram-negative sepsis, it got its right deserving place. Just when we were trying to understand Sepsivac, COVID hit us. And our faith in Sepsivac, because of all this study, I think Dr. Subhal is going to be talking about that, gave us some confidence and made us all use this particular molecule in the management of COVID as well. We at Chest Council of India have witnessed the benefits of Sepsivac. We know that it does prevent COVID. It does prevent COVID from going from mild to moderate to severe. I know NH Krishna made the arrangements for a free Sepsivac to all life members of Chest Council of India and House of CADILA, especially my friend Mr. Amit himself supervised delivery and maintenance of proper cold chain to each and every member. I think they supplied more than 900 injections to their family and family members in this difficult times. I'm a believer of immunomodulator. I'm a believer of Sepsivac. Sepsivac I've tried in more than 200 COVID patients as treatment, especially when they were admitted in ICU. And I have realized it is a good drug to prevent moderate patients from going to severe state. I have also used this particular molecule as a preventive therapy, and myself I've given it to at least 10 of my close associates, to my staff, 2 doses of Sepsivac, and it has worked very well. I can tell you I have not taken a single day off. Since last, of course, Krishna, we went for 2 days holiday, go up, and I think we'll not declare that. In last 1.5 years, I would have used it in, I would have probably seen more than 1,500 cases of COVID and those indoor works. I'm sure everybody here has done that, and neither me nor any of my staff member got it. And I give at least some credit to Sepsivac that I've used. We have a lot of friends here at CCI who have used this in IV form And we have Dr. Subhal here, who will be talking in detail about it, the uses, if it can be used in ICU in IV form, and what we are doing is right or is the right way of prescribing it, especially when we are talking about critical cases. I think that will be taken up in a discussion. I'm extremely thankful to the House of CADILA for giving us this Sepsivac. To tell you about Sepsivac in nutshell, Sepsivac is actually a drug which is developed by CSIR and CADILA together. It is under the New Millennium Indian Technology Leadership Initiative program. That is the New Millennium program. And for all those who may not know what CSIR means, CSIR is the Council of Scientific and Industrial Research. It was established by Government of India in September 1942 as an autonomous body, which has emerged as one of the largest research and development organizations in India. Sepsivac contains Mycobacterium W, which is immunomodulator, which is a non-pathogenic mycobacterium. It is first in the world in sepsis management, and drug has received appreciation from, it is approved drug actually. It has got DCGI approval in the treatment of sepsis and gram-negative shock. I'm very happy to share with you that this particular drug has received the prestigious Pharma Excellence Award in the Emerging Dimensions in Pharma Excellence E-Summit, and it is for its promising results against COVID-19. When it comes to my association with CADILA, 25 years plus association, I had the pleasure of meeting their ex-managing director, Shri I.A. Modi. I'm friends with the present managing director, that is Dr. Rajiv Modi, a great entrepreneur and a great human being. How do I forget my thick pal, Mr. O.P. Singh, the senior president with CADILA currently. My friendship with him for more than 20 years. I've seen him growing from a medical representative to managing director of a company to now president managing huge business of CADILA. 32 years of pharma experience. Trust me, this guy is featured 3 times in Limca Book of Records. He's got experience of domestic, rural, international, and geriatric market. And of course, the entire team led by my friend Amit. Amit also I know for over a decade, who single-handedly looks after 65% of the domestic business, and the entire team, Pratik and I may be forgetting few names. All of them are the brain or the force behind today's program. And I take this opportunity to thank every one of them for getting at this platform and reaching out to so many people that we have at the CCI presence of more than 5,000 delegates. In fact, recently we had more than 9,000 delegates in our program, which we conducted 2 days ago. So with these words, I'm going to present the first speaker, who's none other than my friend Subhal, to give his first talk. Subhal Dixit is the Director of Critical Care, Sanjeevani Hospital, Pune, Director of Critical Care Hospital, MJM, Pune. He is the past president of ISCCM for, I think he took up that position in February 2019. Is a member conference guiding committee, ISCCM. He's held various leadership positions at regional and national levels, and critical care is his core subject. He's joint organizing secretary of Best of Results, the annual international symposium of intensive care and emergency medicine at Pune, joint secretary, education, Indian College of Critical Care Medicine, delivered various lectures and at various national and international conferences. I met him for the first time, Dr. Subhal, if you remember. I think we met at Hyderabad during the international, during the national conference that you had, the critical care conference. And luckily, that is the time when I was part of the Sepsivac launch to the critical care. And I think those study was partly launched by me. So that's all about Subhal. Don't go by his white hair, etc. He looks very senior, but he's our colleague and is our age. With those words, I present Dr. Subhal Dixit. Shubhal is going to be talking about role of Sepsivac in the gram-negative sepsis and emerging role of Sepsivac as an immunomodulator. Over to you, Dost.
Okay. Yeah, thank you, Agam, for the warm introduction and the kind words. And again, thank the CCI for inviting me to talk on today's topic along with CADILA to speak on Sepsivac. I'll just start sharing my screen here. Yeah. So basically, all of us know that, yes, as Agam has justly said, that this is a very old molecule. It's like getting out an old wine into a new bottle and for a new indication. Of course, it has been used for obtain number of years, as he rightly said, right from for the prevention of tuberculosis, treatment of resistant tuberculosis. But this is for the first time. We also in intensive care try to use it for a different kind of indication, which is the cytokine storm, which COVID all of us were hit into almost about 1.5 years ago. And that is the first time when we all intensivists really became aware of the cytokine storm and what cytokine storm is. Yes, various papers also did came up, and which various papers also told us that, yes, it also made us aware that cytokine storm not only happens in COVID, but cytokine storm also happens into any form of infections, whether it's a gram-positive sepsis or whether it's a gram-negative form of sepsis, but mainly into a gram-negative form of sepsis, which is very important. That's what causes the worsening. That what precipitates the septic shock, and that what really hampers the multiple organ failure, and that's what is the pathophysiology into the sepsis in short. So let's see what role of this Mycobacterium W, which is an indigenously developed product by, as Agam rightly said, under the CSRI project along with CADILA, and it has given a good ray of hope for all of us in the management of sepsis. I'll be covering the mechanism of action, the various efficacy into the gram-negative sepsis, which is approved by DCGI up for patients up to the age of 65, and what and how it is useful for immune dysregulation into COVID-19, the Army 1 study, and the prophylaxis against COVID-19, and then in short about the conclusion. But most importantly, you must try to understand that it is mainly the gene profiling which is very important. The gene profiling is the one, or the gene upregulation of the downregulated genes and the downregulation of the upregulated genes plays a very important role as far as the management and the mechanism of action of Sepsivac. We know in short that it's a very potent TLR2 agonist. We know it's a poly-TLR antagonist. It also produces the P38 downregulation, and most importantly, it produces a good amount of a cytokine suppression. Mainly interleukin 6 is the most important and key as far as the COVID management is concerned. And as I rightly said, that gene profiling, the balance and the which is there, a good amount of equilibrium which is produced by the down regulation as well as the up regulation to produce a good symbiotic amount of balance, that is the key. So we know that it's a potent TLR agonist. At the same time, the various potent agonists along with this, which has been seen, that this was studied, and this study was seen in the samples. Along with this, it was also found to be a very poly-TLR antagonist. This antagonism mainly produces the suppression of the inflammatory markers. The suppression of these inflammatory markers is very important, and that's what is the key, and that is the most important aspect as far as the management of cytokine storm, whether you're dealing with a gram-negative sepsis or whether you're dealing with a COVID amount of cytokine storm. The COVID cytokine storm, we know that typically it comes up into the 7th day or the 8th day or the 10th day of the say, that is almost up to after the end of first week or 8 to 10 days. But for more importantly, really speaking, after management of COVID, the exact timing of initiation of the drug, the exact timing of initiation of Sepsivac is most important. The timing of initiation plays a very important role. Rather than relying on the markers as far as the IL-6, yes, it's a very potent IL-6 inhibitor, rather than also seeing the inflammatory markers like the D-dimer, the CRP, the LDH, the ferritin. Yes, we have also seen that these are inflammatory markers which do go up, and they also increase as a part of COVID. But we have also seen studies where gram-negative infections, the CRP levels are also sometimes much more higher than what we see in COVID. The IL-6 levels also much more higher than what we see in COVID. So they play a very important role into the cytokine suppression. And along with the downregulation, we have also seen the JNK, the P38, all of them, they they all produces a suppressive effect into it, and the cytokine suppression plays a very important role. The Sepsivac induced MAP modulation, they inhibit the cytokine production, and that's very important. The tumor necrosis factor alpha, they're also into proportionate levels. So in short, they produce a good amount of suppression of the inflammatory markers which is there. As I said, cytokine 4, 5, 2, 12, and also 6, they play a very important role. And you can see here from the study here where the orange graph which can be seen here, it definitely shows that it produces a good amount of suppression with Sepsivac as compared to the control group. And that what is very important in the management of these cytokine storms, which is thus manifested by means of worsening up of hypoxemia, increased need of oxygen, or worsening up of the patients who progress from HFNO to NIV, or those patients who are onto NIV, HFNO, they also get intubated, or the increased need of oxygen requirement. That is somewhat is the right timing of initiation. Sometimes, and I personally believe that clinically identification of the storm is much more better, but rather than just relying on the inflammatory markers, because the inflammatory markers do take time to come up, and not all facilities are available into all the hospitals in India to have these inflammatory markers to be managed, because they are quite costly also to be studied. So the clinical in diagnosis of storm is most important, and that is actually the clinical way how we should initiate Sepsivac, because it does not produce any much amount of side effects. It is quite safe, it is quite effective, and it has produced definite beneficial effect, and thus it's a pro-inflammatory. At the same time, it has got anti-inflammatory inhibition markers. So the effects what we have seen here, they have been studied. These effects have been studied by means of various models. The models have also shown that there is definitely a suppression of these cytokines, and once they produce a good amount of gene profiling, they produce a good amount of upregulation of the downregulated genes, or the downregulation of the upregulation of genes. They produce a good amount of balancing which is occurring. The balancing mainly produces a good amount of a balance. They also have got a tumor necrosis factor alpha induced proteins, the interleukin 6 effector alpha. So in short, let's not go into the details of these upregulation and downregulation. More important for us, it produces a good amount of a milieu interior. In short, all of it acts together to cause a suppression of these inflammatory cytokine markers which are liberated because of COVID, or oblique by means of a gram-negative organism, and thus it helps to prevent and progression to a multiple organ failure. Now, immune dysregulation, as I said, timing is very important. In sepsis itself is defined as the new definition as per the surviving sepsis guidelines. It's a dysregulated host response to an infection. So this dysregulated host response to an infection really needs to be controlled. And if you have really seen that in case if there is a infection which is there, and if possible amount of proper amount of treatment or optimization is not done, it will definitely produce an organ failure. It will progress into a multiple organ failure, and there will be a early death which will occur in certain kind of patients. But certain patients where you try to achieve a hemostasis, but if proper regulation doesn't occur, there may be also recurrent infections, and these recurrent infections or secondary infections can also produce late amount of death. But at the same time, we have seen that in case if proper amount of immune dysregulation is being carried out, in case if proper amount of immune suppression is being done early in the timing of sepsis, early identification of sepsis, that's what we always say in critical care, that we really need to smell sepsis rather than identifying or diagnosis of sepsis needs to be done. Then early treatment plays a very important role. So early initiation of Sepsivac plays a very important role, especially in gram-negative septicemias, or also in the early worsening up of hypoxemia also can be taken as a part of a storm, and that's what plays a very important key, and that's what can help us to turn the tables around. We know that Sepsivac prevents immune dysregulation. I won't go into the details. We have told you that there is a macrophage, whether it's a gram-negative bacteria or whether it's a COVID virus. Definitely, there is going to be the gene transcription regulation. There will also be the TLR2 antagonism which is there. At the same time, the TLR4 antagonism which is there. But in short, once you have got a good amount of suppression into this, the suppression of these activated macrophages will be suppressed. And because of suppression of this, definitely there will be a suppression of the inflammatory markers like interleukin 6, interleukin 1 beta and 10, along with the tumor necrosis factor. And this response is the one which mainly kills the intracellular organisms. So in short, the timing is important, and they help to prevent the and progression into multiple organ failure, and also and prevents it from progressing into a septic shock. The studies which have been done, this was published way back in 2015. It was mainly a randomized double-blind two-vial comparative study to see the efficacy of Mycobacterium W. Yes, they did see the 28-day mortality, and the secondary outcomes for the delta SOFA scores, or the ventilatory-free days, the time of withdrawal of vasopressors, and the ICU length of stay were taken into consideration. Yeah, the results were quite encouraging. They definitely found that equal amount of patients, about 28, and the mortality was also comparatively percentage-wise was less into the group where Mycobacterium W was used. And if you really see the days on ventilator, the requirement of vasopressor days, the delta SOFA scores, the length of ICU stay, the length of hospital stay, and the chances of secondary infections, whether it's a CRBSI or whether it's a VAP, they were very much less statistically significant into the group where Mycobacterium W was used as compared to a control. And this study was published way back in 2015. Until the time, initially there were phases when we as intensivists were not using it very regularly, till the time we got aware of it and we got known of it very honestly during this COVID pandemic. In patients with sepsis, there was also the conclusion that yes, it definitely produced a significant amount of reducing in the hospital stay, as I said. And importantly, the days of duration of mechanical ventilation was less, and the delta SOFA scores were also less. So in short, it did produce a good amount of beneficial effects. We, from the intensive care perspective, the length of hospital stay, ICU stay, as well as the days on mechanical ventilation. So it also helps to reduce the cost and also the financial burden also into the patient. The MISS study, which was published by Indapol, this again was a randomized double-blind study. They also took into consideration patients with severe sepsis were taken into consideration. The primary outcomes and the secondary outcomes were also same as compared to the first study which was done here. The inclusive criteria is again patients who are defined as severe sepsis or septic shock, where they had urine output were low, the lactates were on the high side. So exact patients of sepsis, or those patients who had lung injury, those patients who had a cardiac dysfunctions with septic-induced cardiomyopathy, those patients who are in shock, or those who needed vasopressors in the form of dopamine above 5 max, or those who needed NORAD or epinephrine of less than 0.25 mics, they were taken into consideration into these patients. And more importantly, at the same time, at least there has to be an incidence of gram-negative sepsis has to be present, and the source of infection needs to be preserved from to the gastrointestinal or the hepatobiliary tract, pulmonary or neurological organs, and they were typically documented by means of blood cultures or means of tissue cultures. And the exclusion criteria was for a gram-positive infection. Yes, gram-positive or fungal infections were not taken into consideration, or those patients who were previously enrolled into the study were not taken, or those patients who had malignancies or other forms of cancers were not taken, and those who were not willing. This study was carried out at multiple sites, where PGI Rohtak was also one, PGI Chandigarh, big hospitals were taken into consideration, Cultural St. John's Hospital. So it was a multi-center study which was conducted in India, and definitely the treatment as well as the arm had equal number of patients. The equal age was also quite sufficient. We also found that into the treatment arm, if you really consider the patients who are on ventilator, the patients who are on vasopressors, the patients who had got abnormal amount of HGP liver dysfunctions, yet it also abnormal creatinine, there was not much amount of difference into both the groups into these patients. But if you really consider the MISS study, more importantly, there was definitely an absolute difference of 11% decrease in the mortality group, and it did produce a significant amount of time, because 11% reduction in the mortality is a quite significant amount of benefit which is there, and thus reduction in the mortality played a very important role, and that's what it's also been approved by the DCGI for use in patients in gram-negative sepsis. Again, the time to mortality, if it was taken into consideration, the time to mortality was also significantly lower into the group, where in Sepsivac as compared to placebo. Yes, it's not that very expensive drug. Vis-a-vis, if you really compare with the other immunomodulators, what we are currently using in the form of tocilizumab or itolizumab or bevacizumab, we have also got other oral in the form of bartinibib, which is available. We have also used ulinastatin, which is also being used in high doses as a form of immunomodulators. The best beneficial results, anecdotally, I can also see have been seen, beneficial effects have been seen with Sepsivac as compared to other forms of immunomodulators without much amount of complications such as infections or chances of other secondary infections which are seen as compared to when you have seen into the Ito group or when you into the Tosi group or into the Bevacizumab group. We know that, yes, I won't go into the details. All of you are quite well aware as to the classification of COVID into the mild, moderate, and the severe form. But more important from the intensive care perspective or from my perspective, any patient who is admitted into the ICUs with hypoxemia or the PF ratios are on the lower side, whether it's acute lung injury, increased need of oxygen requirements or increased need of mechanical ventilator either in the form of HFNO or the requirements go up, that should be taken as a part of a storm. That should be taken as a high index of suspicion of a storm. And definitely we know that a good amount of inflammatory marker liberation occurs into this, and therefore you need to act early. The entire treatment resolves around timing, as which is most important, and which all of you will agree the crux in the management of COVID is early identification of the problem and early initiation of the treatment, of the right treatment, and in the right doses plays a very important role. We know that SARS definitely, or COVID which is there, it is not acted in time. Yes, it will progress. It will produce a certain amount of lung injury. We did see that the second wave which hit us definitely had more amount of lung injuries or lung shadows, although yes, you cannot correlate it indirectly. The amount of lung injury cannot be correlated with the functional requirements or the functional respiratory failure which is there. It cannot be correlated just with the CT severity score. Any patient with low scores can also be bad. Any patient with high scores can also be stable. But yes, more important for us, those patients who are worsened hypoxemia, those patients who are into a storm, they need to be acted early because it can kill. So timing of initiation is more importantly. So the onset of hypoxemia or worsening of hypoxemia definitely should be identified as a part of storm. Of course, some certain institutes do rely upon it, upon the markers as to a 5-time increase as far as the baseline of interleukin 6. But from clinical experiences, clinical judgment plays a very important role, and therefore early identification and early treatment is most important. We know that definitely 20% of these patients, those who are into the moderate or severe patients, do get hospitalized. Yes, recovery occurs. The death rate even is quite very, very low as compared to, if you really consider the huge amount, it's just hardly about the mortality rate, even in the current status, is just about 1.5 to 1.67%. But majority of the times, yes, these 15% of these patients, if not acted early, if not treated early, if not definitely, if you don't take into consideration the timing and proper treatment, definitely it can progress further, and the cytokine induced inflammatory damage can also produce multiple organ dysfunction. It can precipitate shock. It can also increase the need of mechanical ventilator requiring invasive mechanical ventilation, to further increasing the complications and the increased length of hospital stay. So early initiation of Sepsivac is the key. As I said, yes, the spike protein is mainly responsible for the changes into the cytokine. But as we saw, that I won't go into the details of these microbiological figures. Important for us is the TLR antagonism is important. It produces a good gene profiling. It produces a good amount of balance. It produces a good amount of suppression of the inflammatory markers. And that's what is the key. And that was again proven into the army study, which was again done by Inder Paul. He also saw the secondary outcomes of 28-day mortality, the time to clinical recovery. He did publish it into the European Journal in 2021, and he definitely conducted into 4 centers in India. We definitely had 50 patients. They were assigned into 2 groups, also more into the Mycobacterium W group. 1 patient withdrew the consent, 20 patients had intention to treat, and 22 patients were ultimately included into the studies. And they definitely found that there was an early resolution of respiratory failure in the Mycobacterium W group as compared to the placebo group on day 14 and 21. He also found that Mycobacterium W Sepsivac combined with the standard of care was safe and resulted in better clinical clinical states on day 14 and 21 than those receiving the routine care alone in critically ill COVID patients. And he observed that there was inflammatory markers like CRP were less into the group with mild and moderate severe patients into group where Mycobacterium W or Sepsivac was used, and no safety concerns were seen. And that's what even I said at the start, that yes, it's a very safe drug to use and with good amount of beneficial effect. Sepsivac, again, for prophylaxis of COVID infections, as Agam rightly said, yes, he has used it in plenty number of patients. Let me be very honest, I have not used it as a part of prevention of COVID infections as prophylaxis, but this study, which was again is in preprint. There was a randomized study into 12 healthcare workers. The control arm had 64, investigational arm. They were given Mycobacterium W 0.2 ml, and they were follow-up was done for about 100 days. And into the control group, the incidences was 48% as compared to the investigational group. The incidence was just in about 3.1%. And excepting for local mild irritation, which occurs at the site of injection site, no other side effects were seen. And definitely it had good protective effect of almost about 94%. So it's quite safe, quite effective, and this is just into preprint, which will soon be published. As for prophylaxis, again into the investigational arm, what we saw here, the same study, it definitely shown this was a big study. Here they gave it about 0.1 ml was given. It's given about intradermally. I have not used IV, let me tell you very honestly, into the intensive care. I've used it as an intradermal injection, and those patients where Mycobacterium W was used for COVID positive patients who are symptomatic or the COVID positive patients who are asymptomatic, definitely they found that there were beneficial effect into the group and much better results were seen. They also found that definitely there have been a suppression of the inflammatory markers. They also found that the incidences of hospitalization was also less and early recovery was seen into the group. And another study which was again published in Lung India was again done by Inder Paul and with Ashish Bhalla. He found that there were radiological resolutions which were also into the scene, into the group where Sepsivac was used. It did produce a faster effect, and definitely this study had got less number of patients into the group because it was one of the first studies which really got published into Lung India, and he saw that the inflammatory markers also went down by the time of day 5 onwards into all these 4 patients which were there into the group, and he found that there was a significant amount of improvement in the CRP values, and thus the role of Mycobacterium W or Sepsivac for the treatment of COVID-19. This study was again done by and this was published in JAPI, and this was recently published. He found that yes, these 2 studies from Inder Paul as well as from Atul Ingle, he said that definitely the inflammatory markers or the CRP level was statistically significantly lowering down, especially after the second dose and the third dose. There was a good amount of significant statistical resolution which was seen, and that also showed that the impression and the suppression of the cytokine storm and the suppression of the inflammatory markers, thus avoiding further progression into a multiple dysfunction, plays a very important role. As we said that along with this, not only we found that there was a suppression of the CRP, we also saw that definitely the interleukin 6 levels also went down. They were statistically significant, especially into the second dose and the third dose, and this is more important. And the use of Mycobacterium W was associated with rapid recovery into these patients. As we said, there were decreased levels of CRP and interleukin 6 was observed. And more importantly, there was a decrease was associated in the improvement. And in short, this improvement also culminated that these patients recovered faster. They had a less duration of stay into the hospital, and they were discharged also from the hospital within 10 days. And therefore, it is quite cost effective. As we saw into these 4 cases, which was published by Inder Paul, that yes, there was significant amount of resolution which occurred into the patients. Yes, certain patients do take time. If you really consider the worsening up of the X-ray, there was significant resolution which occurred. Definitely, it is also associated with good standard of care. You should not forget that the basics of intensive care and the basics of good critical care management of the fast hug should not be compromised. And definitely, with the compassionate treatment, the fast hug, with early identification of the storm, early use of Sepsivac, and the initiation of Sepsivac at the right time of worsening up of hypoxemia plays a very important role as far as the recovery of patients. This study of IV Sepsivac series of cases, these 6 cases were taken into consideration. They required, majority of the patients required NIV. One of the patients were onto a rebreathing mask. These patients had baseline dyspnea or breathlessness on examination. They also found that, yes, pre-post, if you really consider it, the CRP values and the interleukin 6 values were quite significantly and statistically reducing into the group where these patients required NIV, or those patients who were given intravenous Sepsivac. The requirement of these patients also went down. The inflammatory markers also went down, as well as the interleukin 6 levels also went down into these patients where the IV Sepsivac was used, and thus it produces a good gene balancing and a good amount of gene profiling so as to reduce the morbidity, mortality, decrease in the need of mechanical ventilator, decrease duration of stay into the intensive care unit, and also helps you to reduce the cost burden. And if you really compare the cost factor when you're using it into as compared to the other immunomodulators, yes, it is quite cost effective. It just costs about 20,000 rupees as compared to other immunomodulators, which costs about 40 to 50,000 rupees, and which with less amount of complications. If you really compare it with other immunomodulators, yes, we really as intensivists really got to know about other immunomodulators even at the time of COVID, where they were mainly used by rheumatologists. But the amount of secondary infections, what you really see definitely is much more into the group with other immunomodulators as compared to using Sepsivac. Vis-a-vis, Sepsivac is also approved by DCGI to be used as a part of management for suppression of the inflammatory storms in gram-negative sepsis. So it has got a double-edged benefit, which plays a very, very important role. So thus, to summarize, Sepsivac has diverse as well as potential immunomodulation properties. Sepsivac use in gram-negative sepsis is very effective. It reduces the morbidity as well as the mortality without any major concerns. It is quite easy to use, quite cost effective. In COVID also, it has got a similar picture as what we have seen in gram-negative sepsis. And Sepsivac, when used along with the standard of care, it has produced significant amount of benefit into seriously ill COVID patients into the ICUs. Prophylactic use of Sepsivac has reduced the chances of infections of COVID as well as prevented hospitalization. And Sepsivac has a proven to be a unique amount of immunomodulator with a potential option of prevention of the treatment of COVID-19 infections. So this is to summarize, and this is the pack which is being sold by CADILA Pharmaceuticals. And thank you. And again, thank the CCI, Dr. Vora, as well as CADILA for inviting me to talk on this topic. And I'm very happy to take any questions, if any. Thank you very much.
Great. That was a really fantastic talk. Dr. Subhal, I get amazed by the clarity of your ideas. Not only clarity of ideas, but your capacity to convey those ideas in a convincing way is really amazing. So in the beginning, you had only one fan. I always knew you. I always have attended your lecture. But now, at the end of this talk, you have at least 3,000 odd chest physicians in your fan club. So thank you very much. Welcome to the group. And I'm told that you have joined CCI. So we welcome you officially today as a member of CCI.
Thank you very much.
Moving on, we have the excellent panel here. So with the initial idea of the molecule that Subhal has given you, we are going to have a panel discussion and what the panelists, about the experts across the country feel about immunomodulation, feel about Sepsivac per se, feel about role of Sepsivac in the management of sepsis, in the management of tuberculosis, in the management of COVID, and in the management of overall immunomodulation is going to be the gist of discussion today. There's a slight change. Dr. Krishna just messaged me that people are bored and sick of seeing me on the screen. He said, every time there's a program, you are on the screen and people are just shouting at me. And then he has requested Dr. Tony to be the moderator for today's program. But I cannot leave program like this. I cannot not introduce the excellent panel that I have today. So I'm going to do that job without fail. To do that, first I invite Dr. Varun Pushkarna. Varun is MBBS MD, fellow ICM, MRCP, UK, a senior consultant with Department of Critical Care Medicine, Fortis Escort Hospital, Amritsar. He did dual specialization. He did it in general medicine as well as in anesthesiology. General medicine specialty certification from esteemed Royal College of Physicians, that's MRCP, UK. He has an extensive experience in managing critical ill patients with special interest in managing infectious disease and complication. He is also in charge and nodal officer for COVID-19 services at Fortis Escort, Amritsar. He is a member of District expert committee for management of COVID-19. Is actively involved into public awareness programs and CME programs. His special area of interest is infection, especially COVID-19, dengue, and other febrile illnesses. I'm very happy to share with you that he's a recipient of District Award of Honors for rendering COVID-19 services and is active member of national and international medical associations. With those words, I invite Dr. Varun.
Thank you, sir. Thank you so much.
Next, I have my close friend, Dr. Tony Luke Piggy. Tony is currently a senior consultant and lead Department of Pulmonary and Sleep Medicine. Currently is serving at Dr. K.M. Cherian Institute of Medical Services at Chenganur, Karnataka. I know Tony, or everybody here in the chest company knows Tony as a young, bubbling, active chest physician of our group. He did his, he has got fellowship from Asia Pacific Society of Respirology, Japan in 2018. He is awarded fellowship of American College of Chest Physicians in 2017. He has currently is working here, but then previously he worked at Aventis Hospital. Prior to that, he worked as the hospitals in Perintalamanna, sorry, I can't pronounce it well. His area of interest are bronchoscopy and sleep medicine, of course. In his young age, he is a member of all important chest associations. He is attended various conferences in various capacities. He's chaired conferences at CCICon. He's faculty at national conferences. And with those words, I present Dr. Tony Luke Baby to you. Tony, welcome. Next, I have another close friend, Dr. Shashi Bhushan. Shashi is currently the professor and head Department of Pulmonary Medicine at Victoria Hospital, Bangalore. Is member of COVID-19 Technical Advisory Committee with Karnataka State. Is member of COVID-19 Expert Treatment Protocol with RGUHS, Bangalore. A nodal officer, Center of Excellence, Department of Health and Family Welfare with Government of Karnataka. Shashi, welcome you. I have had the pleasure of being with Shashi and I miss those times. Shashi, you remember every time there is a national conference or international meeting, I would not miss a chance to be with you. And probably it's more than 1.5 years. And last I remember we met at, was it at Goa? There was a national event at Goa. And I think last we met at Goa. Shashi, welcome.
Thank you. Thank you.
Next I have is Dr. Eema. Dr. Eema Chaudhary did his MBBS and DNB, currently serving as professor and head of department TB and respiratory disease with Subhal Medical College since May 2020. She is also the assistant medical superintendent in the same medical college. She has 10 publications to her credit. She is a reviewer in International Journal for Tropical Disease and Health, attended various national and international conferences. Dr. Eema, I welcome you. And last but not the least, my close friend, Dr. Ajay Godse, who practices in the same area where I live. He's at stone throw distance from my clinic, but I have never had the pleasure of meeting him in the last 2 years. That speaks about how busy he is. Consultant, pulmonary and sleep medicine at Bhaktivedanta Hospital, fellow in sleep medicine from American Academy of Sleep Medicine, Emory Sleep Center, Atlanta, he got his fellowship from. He's got professional membership at various associations, delivered lectures at various forums, conducted variety of phase 3 and phase 4 clinical trials. What amazes me the most about Ajay is, of course, his simplicity that you will soon witness. I'm sure you all have heard about his talk at last CCI, Pune, right? Ajay's talk on, I still remember that talk very distinctly. You talk about near life and death issues and concepts on that, and I really remember that. What amazed me the most about him is after setting this practice, after getting busy into practice, he decided to probably learn sleep medicine further. He took almost 1 year. Ajay, 1 year, right? He took almost 1 year off, did not practice at all, went US and did his fellowship there for 1 year. So that speaks about his volume and his dedication for the subject. Ajay, welcome you. So then we have the entire panel ready. I have Subhal Bhai here with me, Shashi Bhushan here with me, Varun here with me, Eema here with me, Tony and Ajay Godse. Before I go on to this discussion, I want to know how many of you have used Sepsivac. Of course, Subhal Bhai has used it. What about Shashi? Have you used Sepsivac? Varun Bhai, Emma. Oh, I think everybody has used. So before we go into the panel discussion, I would want everybody to give me, 2 minutes experience on Sepsivac. Do we start with Tony? Do we start with you? Unmute yourself. Yes.
Thank you for inviting me on this wonderful panel for this very important discussion. Overall, in my practice from the beginning, I have used in multiple levels Sepsivac, and I have found it to be useful from even the early stage of the disease to moderate to severe in many aspects of helping in the recovery. Now, just to give an example, today I have discharged a patient who came in with a 50% saturation with almost in the 12th, 13th day of disease, like late presentation. She needed almost 15 liters O2 just to maintain at an 80% saturation. I have given the patient only the basic medications, no remdesivir, no tocilizumab, only my vitamins, Sepsivac, and ivermectin, and patient is going home today.
Oh, great.
She is underlying severe OSA patient. She's just requiring CPAP now for home.
And do you use Sepsivac in the standard conventional doses of 0.1 at 3 different sites for 3 consecutive days, or you have made some alterations in the regimen?
I have only used intradermal. I never used IV.
Great. Dr. Eema, would you talk about your experience?
So good evening. Thank you. And thank you to CCI and CADILA. Initially, when we got to know about Sepsivac, a group में introduced किया था, then I was very skeptical. But we had nothing, no vaccine at all. डर के कारण सब use किया. I tried it on my family and myself first, and then introduced Sepsivac to the whole group of mine, the task force committee that was dealing inside with all the COVID patients. They were all convinced within a month or two, and we almost gave Sepsivac prophylactic to all our medicos and paramedicos. Fortunately, over the last 1.5 years, it's maximum of 5 of our medicos and paramedics have got involved with COVID. Rest all of us had mild infection and by God's grace recovered well. Now, as regards to the patients, I have used IV in all my ICU patients. We didn't have actually a time to compare between the controls and to have the patients who are receiving the Sepsivac. We tried in all the patients, and fortunately, compared to any other place, we have had good results regarding mortality, morbidity, everything. So I think it did work, and it was fantastic for all our task members to be alive after the second wave also, by God's grace, and whatever thing worked, probably Sepsivac.
Great. Who gave you that Sepsivac? You took it yourself or your sister? No,
I took it myself on my thigh. Yeah, I gave it myself on my thigh and to all my family members on the deltoid.
And you gave proper intradermal, you made it subcutaneous?
Yes, intradermal.
Oh, great. Amazing.
Intradermal. My kids are small. I give all my vaccines to my kids myself. So touch wood, I have a good skillful hand.
Oh, okay. Get your point. Varun Bhai, so you're going to be here today as a physician, or you're going to be here today as a anesthesiologist, or you're going to be here today as a critical care guy, or I see you in a very fit condition. You do gym, etc. also regularly?
No, sir. It's like not right now. Like, no, 2 साल से तो कुछ नहीं किया है. सिर्फ COVID किया है.
Oh, cool. So I can see that you've done your job very well. इतना भागा है COVID के पीछे के I can see your body like, ish, good. What's your experience, Varun?
So, sir, actually, I was the first one to start using Sepsivac for COVID in Amritsar. I work at a tertiary hospital, so we get patients of all sorts being referred from other hospitals as well. So initially, I used it only in patients who had come with, certain degree of severity, because it was an easier task to explain it to the attendants and convince them also that we have this new molecule and we want to use it. And so that was an easier task then. But I started using it, not all the patients, but then some patients who got convinced. And then initially, I work in a place where we do have, ECHS empaneled patients as well. So they would not give any clearances early on. So we would not be using there as well. So I had a certain cohort of patients where I was using this Sepsivac. What I found out was like a little different from what you all might have experienced. One is that, even if you use it in a serious state of affairs, when the patient has just come in, referred from other hospital, he might be having nosocomial septicemia along with. What I saw was these patients would not develop pulmonary fibrosis as a complication later on. So
interesting.
This is one. Second, all the patients who received Sepsivac, I could not find even a single patient till date who developed spontaneous pneumothorax or pneumomediastinum. So So this is something that I have discussed it in my local forum as well. And I have discussed it with the people from CADILA as well, because they have not been, looking at that aspect. Later on, when, the usage increased, we started using it in the patients, and also the patient number increased. They started pouring in randomly. We had to convert our hospital into a COVID hospital itself. Then, in fact, we got it into the protocol, because I obviously am on the protocol making committee of the hospital as well. So we got it into level 1 patients as well. So what we experienced was, although many people made fun of me that you put the Sepsivac even in those patients who would have survived nevertheless otherwise as well. But then we don't even know which patients would progress to moderate and severe. Nobody has a fixed formula for that, and we don't understand the phenomena so true. Honestly, we don't understand it that well. So having such a drug in your armamentarium, which, as Dr. Dixit also told, has so many, the mechanism of action involving upregulation and deregulation, and at the same time, the gene profiling, I honestly got that idea pretty well. And I have used it around, more than 500 patients now. And I have absolute, I'm totally convinced for the use of this molecule in preventing the progression from mild to moderate and then to severe. And second, I can bet you I have not seen any patient presented within first 15 days who went on to have pulmonary fibrosis after getting Sepsivac. This is, later on we keep using, nintedanib, and we keep using pirfenidone to no avail. But in all the patients, you also will have a retrospective look at wherever you have used Sepsivac, and you will also believe in this fact that in all the patients you might have also used, you would not have seen pulmonary fibrosis. Their exercise capacity, their ability to move from 1 ball to 3 balls on incentive spirometry, and their ability to move out of the bed, let us say on day 6 or 7. So this is my experience. I have not used it in gram-negative sepsis as of now. I still, need a little more convincing for that, because maybe I have not ventured into that arena. But then I have found it a pretty useful molecule as far as COVID is concerned, and much better than ulinastatin, much better than Dosi, much better than all other immunomodulators combined together. You can place Sepsivac in one side of, the tarazu, and you can place all of them on the other side, and still it would weigh heavier than all of them together.
Good. I remember talking to CADILA team, probably after inputs from you, they did speak to me about the observation that you had, that there is a significant reduced number of pulmonary fibrosis in cases of pneumothorax and pneumomediastinums are reduced. That's a lovely observation. As Dr. Eema said, everybody is so busy into just treating COVID that we have not got enough time to analyze our results, and we've not got enough time to look at the various outcomes this molecule may have. But I think that's a lovely observation, and I'm sure after this particular meeting, a lot of us are going to dig out our data and look at whether our patients also have got this advantage. Shashi, what about you? What do you think? How have you used it? Where do you give this Sepsivac? You give it in the arms, you give it in the stomach, you give it at thighs. What are your views on Sepsivac?
Yeah, thank you, CCI and Team CADILA for giving the opportunity. Thanks, Dr. Agam.
Agam bol rahe, we are friends.
Yeah. I will just tell my experience with Sepsivac and then go with your question. Regarding Sepsivac usage, I've used in COVID only. And it is there in our state guidelines. So probably ours is the only state which...
yes, I'm aware. Karnataka was probably the first state to put it in their guidelines. Yes.
Yes. And that what our experience, I just want to make a note of certain things. Right? It was used as a substitute for tocilizumab in severe cases. But my experience, what I would suggest is early usage of Sepsivac would be a better option. Okay. So probably at the moderate level would be a better option so that you will not see that the patient gets into a severe form. So that's my observation. So we have used, I've used in only COVID, not in that too in the previous, in the first wave. So that was the experience I had. Coming up to the Sepsivac injection, I would prefer a deltoid or a thigh region. The deltoid would be more better and expertise injection that the nurse or whoever is giving should be trained, because what we have seen is several injection reaction can happen. It can be a large ulcer, leads to an abscess formation. So if you don't give the injection properly, definitely these can lead into a complications like. So a trained healthcare worker, a trained staff should be taught how to give especially a Sepsivac through intradermal.
Look at Tony's face. When you talk about trained staff and nurses, and you can see a big smile on Tony's face. But anyway, Tony, we are not talking about beautiful stuff. We are talking about a trained staff. Okay. Anyway, we move on to thanks, Shashi. That was a lovely input. Ajay, coming over to you. Have you used Sepsivac and in which situations would you recommend?
Thank you, Agam. Thank you for the lovely words on my introduction.
Deserving words.
Thank you, CADILA. Thank you, CCI, Dr. N.H. Krishna, for inviting me into this particular webinar. Okay, regarding Sepsivac, I would give 5 stars out of 5 stars to Sepsivac for a prophylactic use in a COVID. The whole family took it, and probably everybody in a Bhaktivedanta hospital and family of Bhaktivedanta hospital is still wondering why I haven't had a COVID till date. In spite of I don't use a PP since 11th of May 2020. I use only N95 mask. But probably that credit, I would definitely give it to Sepsivac, because even my wife works in a COVID in an endocrinology, being an endocrinologist also in a Kokilabin, and she even never had a COVID. My both kids are safe. Whoever has taken COVID in my clinic staff also never had any sort of a symptom of COVID in last 14-15 months. So thumbs up and 5 stars to Sepsivac for prophylactic use. Now regarding therapeutic use, I have a mixed bag experience. But probably the blame goes to me, because I was using Sepsivac. I had a word with a lot of chest physicians through CADILA about the use of Sepsivac. Most of people who use Sepsivac used it in the early stages of COVID, moderate stages of COVID. And probably the forcing reason was they never had an opportunity of using a tocilizumab and bevacizumab. Probably some tier 3 cities never had an availability of tocilizumab and bevacizumab. Tocilizumab in the first wave and bevacizumab in the second wave. But I probably had always a stock of both the drugs. So I always compared tocilizumab versus Sepsivac or bevacizumab versus Sepsivac when the time to give it to. And we all know that we give a tocilizumab and bevacizumab only when there's a sudden increase in oxygen demand from 3 liters, somebody goes to the 9 liters or 8 liters on the same day. The timing is important. You give a good either IL-6 inhibitor or something like a bevacizumab VEGF inhibitor. Whenever I use Sepsivac at this particular point of a time, when things are little out of control, Sepsivac has not really given me a result, especially in an intradermal form. Recently, since that time I had a discussion with other chest physicians of the thing, I changed the timing of introducing Sepsivac, and that too in an IV form. Now I'm getting the results. That's the whole thing. But this particular change is happening since last couple of weeks only. So my experience with the therapeutic value of a Sepsivac is still in a very small numbers. probably in a 2 months time, I would be in a better position to talk about therapeutic effect of a Sepsivac, because then I would probably use it at an earlier stage before really person goes into the high oxygen demand phase, and then that would be a better input from my side. But yes, prophylactic use, it's a phenomenal drug. In fact, I'm going to say certain things in my discussion, how this can be used as a prophylaxis, not only in a COVID, but most of the other things also. It's a beautiful drug to have it. Thanks, Agam.
I must tell you that Ajay has done a lot of work in COVID. He started managing COVID. I think he was one of the first, physician to start COVID in the private era. That time there was a lot of confusion whether COVID will be managed in the private sector or only in the designated places. And he and his team started working on it. In fact, he started working much earlier than when I remember discussing about the treatment protocols, etc., that he designed for his hospital. And yes, I witnessed none of Ajay's girlfriend also got COVID. So that speaks volumes about his faith in the molecule. He gave it to his girlfriends also. So I think that speaks volumes about, one would give it to wife for sure, but when it comes to giving it to girlfriends, I think you need to have enough confidence in that. Subhal, what about your experience? Have you come across any side effects of it? A lot of times, that scar and that ulcer formation and that first formation which takes weeks to go. Do you think it really comes in the way, or patient come out and tell me, "Sir, COVID to acha ho gaya, but this is not going." How do you manage that?
No. Honestly speaking, I have not seen any complications per se with Sepsivac intradermal injections. I have not had any experience to use it intravenously, in which I must have used it in approximately about 175 odd patients into these patients. The data is still under analysis from my hospital, where I've already taken out the data. And approximately, I've not had any complications excepting for patients complaining of local itching. That is for a few days after the intradermal injection. Otherwise, I have not had any serious complications as far as that into this. The second, if you really compare it as far as the skin ulcerations, I did not found they were not taking time. The skin ulcerations we found especially into the second wave of COVID, not as compared to the first wave. And they were mainly into those for subcutaneous injections of low molecular weight heparin, rather than in those patients where Sepsivac was used. None of the patients where Sepsivac was given, you had any incidences of any ulcer formations which are there.
So, Dr. Eema, you wanted to say something?
So, two things.
You need to unmute.
One is that we have had now the experience of around 3,500 patients. Am I audible, sir?
Yes. 3,500. The system was shocked when you said 3,500. It went as still.
See, I'm the nodal officer also, sir, and I'm managing almost all the critical care patients, supervising them, and I'm the only faculty in my department. So, handling everything, there were three things of note. The second day, whether you take the prophylactic dose or you give the intravenous treatment dose, the second day is a bit worse for all. Prophylaxis they'll have malaise on the second day, and your patients on the IV treatment would dip a bit on the second day. But third day on, they have a sudden turnover. The ones who are to change, the ones who are not changing and are critical enough to be on ventilator, yes, nothing worked. We tried everything, nothing worked. Once in a blue moon, or maximum around 10 patients, we could save out of the ventilator over the whole lot, especially in the second wave. As regards the blisters, we have had the blisters in all our residents or the paramedics who had a vaccine, COVID vaccine, and a Sepsivac taken in less than 2 months gap. For people like me and my family, no, nothing. We in fact took a booster also this year, and out of all my family members, only my husband got that typical ulcerative kind of lesion, though he doesn't scream on me, possibly because he was dealing with his parents at that time who were under COVID. So probably he had a huge inflammatory response kind of thing.
The husband and mother and father-in-law that create problem, right?
No, sir. This is husband mein hua. Mother and father-in-law mein nahi hua. He's still dealing with that ulcer. So the ulcers are there. And the rest of the people, in fact, me too, we have had huge guard type bana hua hai, but that stays unbothered, unaltered, that stays.
I also had the same experience. In fact, I had a small kind of swelling there, which remained for almost 2.5 months. It did not ulcerate. There was no pus formation. But as Subhal was saying, if you don't give this proper intradermal, and as Tony was saying, if you don't have a good-looking sister, and if you're not properly focusing well, it may go subcutaneous. And if it goes subcutaneous, you may have issues. Right. So that's probably the point. I see Krishna coming in. Krishna, you have a comment to make? Since we were talking about beautiful sisters and Krishna makes presents. That is what is Krishna's quality. We are talking about beautiful girls and sir prakat hue hai. So sir, aap kuch kehna chahenge about sisters, nurses, injection giving qualities?
Well, Agam, before I should tell you, as good as Sepsivac, Agam is the same equally opposite to Sepsivac. Because whatever he tells about others, it's what he's doing.
No, घर से बात करो, बीवी इधर है, शुभल जानता है कि Bijal is terror.
He does what he'll keep telling to others. So that is it. Now, the reason I interrupted here, and I didn't want to, but why I'm here, the reason is, we are having 1380 logins.
Wow.
And that is fantastic. And also our YouTube channel upload will always carry beautiful number of logins. Even after the webinar is over also, you'll have a good number of viewers for our YouTube channel also.
I told you, Subhal bhai, that you're going to have all new fan club today.
Kaji?
Subhal bhai, I was just talking to him that you're going to have all new fan club today. He was always popular in his critical care society, but now he's popular in chest group as well.
No, now he's chosen for CCI. Now he has to worry and he has to provide his time to CCI because we'll be picking him for our best movies as the hero.
Anytime, most welcome.
Thank you. So I will add to Agam what he's telling regarding Sepsivac, my experience. Am I audible clearly?
Yes.
I'll just put it in a nutshell because I will not take much time. I want the discussion to go on fantastically. Sepsivac, it is like Dashavatara of Lord Vishnu. You can use it at most of the places and you can use it in most of the ways. And it's all discussed now by all the panelists that how this happened. And I tell you, it is very important to understand that because it is probably, I don't know whether it is got some issues that it's an Indian molecule, it's not so much highlighted. And the abroad, the foreign molecules, as we all are fascinated of, we go behind them. But it is time that we understand, because with my last experience with Sepsivac, wherever I used it, I didn't have any issue with anybody, let it be prophylactic or therapeutic. And more so, I have tried using this in IV also with MOF. And we have fetched very good results. 0.6 ml dissolved in 100 ml NS, which is run under a steroid cover for a duration of 1 hour span, which will be repeated daily for 3 days. So this has worked wonders. And regarding the ulceration part and regarding the scar part, you should basically understand that whenever you take a BCG vaccine, what happens, the similar things tend to happen here. And you should tell to your staff or anybody that strictly use insulin syringe. 4 units of a 40 IU insulin syringe is equal to 0.1 ml. If the technique of administration should be intradermal, and having an insulin syringe facilitates the intradermal mode of administration becoming very easy. Also, you can see a visible needle passing beneath the skin, you give it. All the issues regarding the ulceration, the abscess part and blah, 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 they are all related to subcutaneous, it is passing. So other than that, prophylactic use of Sepsivac, see, I tell you, I have given it to probably 15,000 people across the nation, having the both the CCA doctors and their family members and their relatives. And these 15,000 people were given, this Sepsivac was given free of cost by Mr. Amit Jain and CADILA. And amongst these 15,000 people who were administered, none of them had a severe COVID, and even if they were COVID positive, they were only mild COVID asymptomatic. asymptomatic rather, who didn't have any symptoms. They were asymptomatic COVID and they got well soon with this only, what do you call that, paracetamol, vitamin C, zinc and all such only. I would like to quote an example here without naming the doctor in CCI who is from Maharashtra. His dad, who is 90 plus, his mom, who is 80 plus, his wife, himself, everybody turned out COVID positive. But thank God they had taken 0.1 ml Sepsivac prophylactically with a gap of 15 days. And can you understand, everybody stood asymptomatic and everybody came over without anything. So as Dr. Ajay Godse said, I will definitely tell, out of 5-star to Sepsivac. See, I'll tell you, believe in something. Definitely. You are giving a trial to everyone. Everything under the sun, including the heat of the sun, is used in treatment of COVID. When you are using everything, you give a try to Sepsivac, and I will tell you, only when you use it, you'll understand how beneficial it is. Definitely, I support Sepsivac. It's not because that I'm doing this event, but I will tell you, actually, I accept only such activities which my inner conscience accepts. It's not for my side, like my benefits. It is the benefit of the entire society. Dr. Subhal wants to speak something. Please, sir.
No, Dr. Krishna, rather than speaking, I would like to ask a question here.
Yes.
That you have one of the vast experiences of using it prophylactically. Now, majority of the people or majority of us here, like I have not taken Sepsivac on a prophylactic weight. No, I did not have not that amount of knowledge for prophylactic use. Now, do you recommend, like majority of the doctors must have completed 2 doses of either whichever part of the vaccine. The vaccines are supposed to give efficacy about 75% to 80%. With the study for prophylactic use, which I just showed, that definitely the efficacy with Sepsivac is 93.3%. So do you still recommend Sepsivac should be given for those persons who have completed both the doses? That's the first part. The second part is, after completion of suppose both the doses, what should be the gap in case if Sepsivac needs to be given? What should be the duration or the time interval or the gap, and how it should be given, and how many doses should be given for prophylactic use, especially in those who have not had, but those who are fully vaccinated with a vaccination certificate?
Very good. It's a beautiful question actually, and the study is right now actually going on. And I will tell you only those points which could be uttered here because the study is yet to be published. But with my experience, I will tell you, see, those who have taken Sepsivac earlier when the vaccine didn't arrive at all, those days we provided Sepsivac to everyone pan-India in a CCA population. Following which who took vaccination, we do recommend the national program vaccination, definitely not only Sepsivac. The main part of your question is, who have taken the vaccination, both the doses, should they go ahead taking Sepsivac? I will tell you a definite yes here. Definite yes here. And with this study, they are approaching the government of India also now. This study is going to get published very soon. We'll come out with the entire details in the CCA platform. These people, if they are given 1 dose of 0.1 ml intradermally post-vaccination also, the 70% efficacy rises up to 85%, and the efficacy with 2 doses of 0.1 ml Sepsivac with 15 days apart, it will go up to even 98%. This is the study. This is the answer for the part 1. The part 2 where I need to answer is the gap between the second dose of the national program vaccination and the Sepsivac, how much this should be. That is your second part of the question.
Yes.
So, yeah. So I am of the opinion personally, other than the study's outcome, I am of the personal opinion that giving Sepsivac at any instance, even after a week and even after a 15-day span of post-second dose of vaccination, should not matter, because the mode of action of both are totally different, and this is only an immune modulator. Because this is an immune modulator, it will tackle all the variants of COVID invariably. This is an immune modulator basically. So the pathway of that vaccine and the pathway of action of Sepsivac are totally different. So this could be administered, I believe, even 1 week span after the vaccine also. The reason of quoting 1 week here is because the vaccine is also given in deltoid region to avoid the same site pain. I'm suggesting 1 week. Other than that, I do not have a reason to give any example of the duration for this span. But Sepsivac, if taken 0.1 ml with 15 days apart post-vaccination, is definitely highly beneficial as per my own experience. And this is going to get documented soon. And we are coming out with that. And very shortly in CC, it will be published. Thank you for such a beautiful.
That's a fantastic reply. You may have vaccine which may give you protection against some variants, and then you may have probably disadvantage with some variants. But here it's a non-specific immune booster, and it would give you probably immunity against variety of infections, not only COVID but various others as well. So what Krishna said, the take-home message from Krishna's talk is why it is not famous, because it's Indian. That is what he was trying to tell us, that Covaxin probably did not get as much popularity as Sputnik. And Bhushan was just talking that vaccine to Russian hi chahiye. Bole baki kuch Russian mile nahi mile, but vaccine to Russian hi chahiye. So that's what people's love and faith about international reserves, your national thing. And what Krishna said is probably with vaccine there is no problem when it is your husband and when it is your mother and father. And what Eema said, there is a problem when it is your husband and when it is your mother-in-law and father-in-law. So this is the take-home message from this discussion. Yes, Varun, you are...
Bye-bye, everyone. Carry on.
Yeah. Just a second,
Great job. Great job.
Krishna, you're required.
Everyone. Thank you so much.
Krishna, you're required. Varun wants to say something.
Hurry, go ahead.
Thank you. Now that everybody's saying that this third wave could involve the kids as well. So, are there any guidelines that you are preparing for the use of Sepsivac in children during the disease and as prophylaxis, both?
Actually, I will tell you, waves actually do not matter to Sepsivac at all. Let it be first wave, third wave, 10th wave, 14th wave, 15th wave. I'm sorry, so many waves do not come. But waves do not matter to Sepsivac because Sepsivac is accepted everywhere at every scenario. Sepsivac is how, it's like, Paresh Rawal, who can get fit into anywhere and he excels the movie. He need not
any changes of dose in children?
I will tell you, I have tried it brilliantly over the age of 10 years. But below 10, I haven't tried. But Dr. Vibhu Kawatra from Delhi has tried it with his own children who are 8 years also. So, I will not comment on that. Why? Because my experience was about 10 years. I have given it to my own son, my sister's son, who are below 12 while getting that administered for prophylaxis.
That is 0.1 units. That's it.
Yeah, 0.1.
And two doses 15 days apart, right?
Yeah, 15 days apart.
And if you really want Krishna to take up this project, Krishna can give you this, information maybe 2-3 years down the line. He may take advantage of this next lockdown, next wave, and can produce future plans, can have children, and he could use that particular, immunomodulators in those.
You mean I should start producing more children now and try on them?
Yes. You remember that shairi you told me the other day? Subhal, Krishna gave that shairi.
Whatever you tell are your experiences only, not
everybody knows how Krishna. Naam mein Krishna likha hai, so you can imagine how notorious he must be. So he tells me one shairi one day. He tells me one shairi that is jahan mein aaye ho, to kuch aisa karo kadardan. Is jahan mein aaye ho, to kuch aisa karo kadardan. Jis gali se aap guzre awaaz aaye, Abba Jaan. So that's what Krishna is all about. Tony, I would request you to take over from here. Thank you, everybody. I will have to leave since Krishna also left. I also feel like leaving, but then trust me, my personal experience with Sepsivac, it is a very good molecule. I have been using it for last 15 years. I've used it for tuberculosis. I've used it for sepsis. And of course, in COVID times, everybody will have major experience with COVID. I believe in it. I believe it can be a good drug for prophylaxis. I believe that it could be a good drug when your patients are in moderate stage. It can prevent the transition from moderate to to severe cases. I have used it in small number of patients, IV preparation, as was discussed earlier, but most of my patients have taken it intradermal. I wish all the best to the CME. I wish all the best to Sepsivac. Thank you, Subhal bhai. Thank you, Shashi. Thanks,
you.
Ajay.
Thank you
Dr.
very
Eema.
much.
Tony, please
Thank
take over.
Thank you.
Very sad that Agam sir had to leave us. He would have been an exemplary host for conducting this session. And of course, I cannot match sir's joking potential and to make the audience laugh. But I would like to invite our esteemed faculty. And now I think we should proceed for the question session, which the audience is sending it to us. So I think, may I direct the question to each member of the panel? Yeah, okay. So I would like to first, now the problem with Sepsivac is that we are having multiple topics or areas of interest where we can utilize it. First, as the first preparation used to be for sepsis, then another indication is for TB, and now as of now, latest is COVID. So I think we will cover each topic separately. So I would like to ask Dr. Ajay sir, that sir, which according to sepsis, what so the application of SOFA versus Apache, which one would you prefer more in your practice, and how do you find the indication of let us say a role for Sepsivac in that?
Both are basically a good scoring system. Both do the same thing of predicting severity of disease and predict the mortality of the adult patient. I'm saying adult patient who are admitted into intensive care unit. So both talks about intensive care admission, adult patient, and prediction of a mortality. Now the difference between Apache and SOFA is Apache has 4 versions, but we commonly use Apache 2 because it's most sophisticated version. So let's focus this discussion on Apache 2. Apache 2 has 14 variables, whereas SOFA has 6 variables. Apache always works when you get to see patient first time in an ICU. If patient is in an ICU, your ICU, you can use Apache. If patient is transferred from another ICU, you cannot use Apache. So that's a limitation of Apache 2. 14 variables talk about acute physiology and chronic health evaluation. So it talks about age, it talks about chronic comorbid condition, it talks about the various parameters, pulse, BP, respiration, FiO2 PaO2 ratio, everything. Whereas SOFA talks about only organ dysfunction. So whether it's a renal, whether it's a cardiac, whether it's a respiratory, whether it's a neurological, or whether it's a hematological. So SOFA talks about 6 variables. SOFA is not a one-point data collection. SOFA is a sequential. SOFA's full form is sequential organ failure assessment. So you can use SOFA score at the time of admission, at the end of 48 hours, at the end of 96 hours, at the end of 6 days. And you can see the difference of a SOFA score. So to answer your question, I would prefer Apache and SOFA. I would use Apache and SOFA at the time of admission ICU, and I'll keep using SOFA as a sequential measure when patient progresses. Now, let me put this particular answer in a COVID perspective. We all know that COVID, when they come to our place, they are not necessarily severe. They can be mild. They can be moderate. So your Apache score would be probably very less. Your SOFA would be also less. But this particular disease is so dynamic that in a span of a few weeks or span of few hours and days, it becomes severe. Your Apache doesn't give you that particular opportunity to predict the mortality at the initial phase, but SOFA actually, because it is sequential, it actually picks up those dynamic processes of a COVID-19 in a better way. So SOFA is better for a COVID-19. But for all other ICU patients, I would prefer initial part, Apache and SOFA together, and in a progression of a disease, use a SOFA.
Thank you, sir, for such a clear answer about the topic. And so now I think I'll take the next question to Dr. Subhal. Dr. Subhal, are you here?
Yeah.
Sir, yes, sir. Sir, now that we know that in sepsis, one of the basic drugs that we use according to guidelines are the steroids. So I would like to know what do you feel is the role of steroids in sepsis, and which is the preferred drug, and how long it should be used, and what limitations would you consider in its use?
See, honestly, as for the surviving sepsis guidelines, there is per se pure sepsis without septic shock. There is no role for steroids as such. Only if steroids are indicated, say 50 milligrams 6 hourly hydrocortisone for refractory septic shock, which are not responsive to vasopressors, only after full optimization of IV fluids. So you need to optimize fluids. One number, you should have proper doses of vasopressors which are there, and then you can initiate hydrocortisone 50 milligrams 6 hourly. That's the only indication. But all patients of sepsis don't get steroids as a part of routine protocol treatment.
Okay, sir. Thank you, sir. And I would also like Dr. Varun to hear. Yeah. And Dr. Varun, you consider, for example, now that we're talking on sepsis, the role of immunomodulators in the management of sepsis itself and the effectiveness of various immunomodulators that are currently available in the market.
Yeah, actually now as definition of sepsis itself is changing over the last 20 years. It has now come to the point where we call it a dysregulated immune response. So that is how initially how everybody started thinking of using immunomodulators, because all other goal-directed therapies we have tried, we have used, and still not reached the point where we can assure 100% recovery. Still we are far from it, even after using so many immunomodulators that are there. Probably it is the timing of administration of immunomodulators. Of course, the initial as the surviving sepsis guidelines go, the initial things that we have to do, like volume replenishment, usage of right antibiotics and empirical coverage, and doing extensive hemodynamic monitoring. But immunomodulators, they will obviously, eventually they will find a place in surviving sepsis guidelines as well. Already steroids, as Dr. Dixit said, are already there. They are just one class of immunomodulator. So we have used till today almost all kind of immunomodulators in sepsis, and more of them in COVID as well. I mean, we would not have used IL-6 inhibitors in sepsis because they indirectly increase the mortality of septicemia and increase the invasive fungal infections. But other than that, urinastatin and so many others are like immunoalpha, and I've used all of them. But then, the promise that they can offer is far from real. Again, I would say that our insight into the sepsis, its immunodysregulation, and timing of its administration. So there needs to be a certain data which has to be compiled on the basis of when and which parameters to be followed when these agents are to be used. They are seriously lacking right now. So eventually what we'll see is these immunomodulators will find their place, but then we'll have to energize and channelize the societies at large, the academic societies at large, to conduct RCTs on this front, that they have to inculcate this modality into management. Obviously, many people are also using IV immunoglobulins in management of septic shock as well. So these are all anecdotal data that are coming. Nobody really has, anything which is like written on the wall that, okay, this is what's happening. We have used, we have done IV fluids, we've done antibiotics, we have the patient on vasopressors, and the patient is still going spirally down. We've introduced steroids. Is there anything which can stall this process? Is there anything which can stall this irreversible tissue death? So maybe, we'll have to find a way where we intervene with all these agents. Still, I would say we are standing at the shores of the ocean. We don't know where to go from here on. We have a plethora of them available in the market, available to us. And, we keep using them at the behest of, sometimes pharmaceutical pressure, or sometimes according to our interest. But then honestly, Sepsivac is something that, I would love to try in a patient of septicemia, although I have not used it till now. But then the rewards and the satisfaction that we get after using Sepsivac instead of using urinastatin and other agents, honestly, I would pitch in them against Sepsivac. And this is how I see the things moving on from here.
Dr. Varun, just to add on to your point, as you had mentioned, that most of the COVID patients that you have handled, where you have utilized Sepsivac, you have not had the undue pressure of the patients proceeding to sepsis. So the I think the most of the issue is that would you consider that has prevented the patients going into sepsis in the first place? When most
Wonderful.
won't use Sepsivac, patients usually die of sepsis once they enter into the COVID phase. Would you
Wonderful observation. Yeah, actually, even after using Sepsivac, these patients, they do die of septicemia and septic shock. When I was saying about pulmonary fibrosis and pneumomediastinum, it was only in the patients who survived COVID. But those ones who could not make it, again, probably it could have been an error of judgment as far as the timing of the drug is to be considered, or the error of administration as well. And maybe there is an equilibrium and the balance between inflammation and anti-inflammatory agents that we are using. Probably that we could not manage it at the particular time. And once the cell death ensues, I honestly feel after that irreversible step, the patients, they really go on to a downward spiral.
I think by the time we reach the end organ damage stage, then it becomes difficult to get back. So probably an earlier administration may prevent progression to that stage. Thank you, Dr. Varun, for your excellent answer. And now I would like to invite Dr. Shashi, sir. Sir, can I ask you one of the questions? Sir, now in the critical care setup in an ICU, when we are handling the patient, how do you feel it as an issue or a troublesome factor to give an intradermal application for the Sepsivac administration, or do you prefer the IV or any other mode of administration?
Yeah, this question is already answered. We have had a discussion initially. As we know that Mycobacterium W injection can cause erythema, induration at the ulceration at the site of injection. So it's better that we need to take adequate precautions and should be given by an expert, by a trained health expert or a trained healthcare worker. So that is the take. And we already told about the how much has to be given, how the technique has to be given. Dr. Krishna has explained, like it's very simple. It can be given even in the ICU setup, should not be a problem, but with precautions.
Because I'm still giving intradermal only to my ICU patients.
Yeah, intradermal only.
Much of an issue. Okay, now I think I'll take one question myself too. Sepsivac and its fitment into the treatment protocol of sepsis. What should we consider as a time to administer Sepsivac to have its maximum benefit? Now, considering sepsis, the issue is that probably when we find that the patient is not responding to the first line and broad spectrum antibiotic that we have given, and patient the CRP is going up, the procalcitonin is going up, probably in that early stage may be the correct time to give the intradermal administration, is what I feel personally, because when whatever happens when we administer the intradermal application of the drug, we have to give it over a 3-day period, and we have to give the time for the body's immune system to kick in and start up. It does not start immediately, like the way we use other immunosuppressants to suppress the immunity with an immediate action. And I don't think it's there with Sepsivac. It takes a bit of a time for the effect to come in. So maybe a patient where we have a poor predictor score, like what Ajay was saying, if you have a poor score where we know a patient is going to progress badly, there probably if you give it a bit earlier, we can prevent the patient going into a florid sepsis and maybe have a less torrid course in the ICU. That would be my take. And if any of the other panelists would like to add anything of their experience, it would help. So then now shall we step into the topic of COVID-19? Because we have a few questions there too. Dr. Eema?
Yes, Dr. Tony.
The cytokine storm, what do you see in sepsis versus what you see in COVID? What are the key similarities or the differences you have felt in what you have seen? And the second part of the question would be, where or what would be the role of immunomodulators in the management of COVID-19 itself?
So basically, the cytokine storm or the cytokine release syndrome, they are the systemic inflammatory response syndromes. They are actually because of the elevated levels of circulating cytokines, and there is immune cell hyperactivation. Now, these can be triggered because of anything, as we have discussed, sepsis, COVID, in fact, in cancers and autoimmune diseases, in many of the disorders. Now, the similarities depends because the basic mechanism for all these remains the same. But so there would be multiple organ dysfunction, there would be immunosuppression, there would be disseminated intravascular coagulation, abnormal coagulation profiles, there would be increased bilirubin, hypoxia, decreased GFR, and hypoalbuminemia. These all would be the same, whether it be the sepsis and COVID-19. There would be acute respiratory failure involving the cytokines increase that we have seen on the tests. But the differences lie that, especially in COVID, the venous thromboembolism or the arterial thrombosis is more frequent. Then there is more of immunosuppression in the COVID-19, while there is more of cytokine storm in the sepsis. This is in general over the whole COVID rather than just the cytokine storm phase. Then in sepsis, we'll have systemic hypercoagulability and decreased fibrinolysis. But in COVID, the incidences of local thrombus formation are more. That is what we saw in possibly more in the second wave. Other than that, COVID can predispose to sepsis, but independently, sepsis is not said to predispose to COVID. So these are the major differences that we have.
And Madam, what about the immunomodulators you would find?
Immunomodulators would depend upon, see, we have had a whole the cycle of which all cytokines and chemokines are involved. So if I'm not able to share my screen, otherwise there's a beautiful diagram. I'll try to put it forward by the time you are discussing with others. The basic inflammatory cytokines that are involved, one by one, if we take these, where to inhibit them, all the immunomodulators are acting on those. So inclusive of tocilizumab or Sepsivac, or we have the IL-6 inhibitors, especially the itolizumab, whichever you pick up, all these, as per my personal experience, we have tried everything. But in the end, I still believe if the patient has to go, whatever you keep trying, the patient would go. If it is to come forward, any of these would become the mediators and you would become the medium. So I'll still put forward the diagram that you are wanting about the immunomodulators. I'll try to put that forward. That's a self-explanatory and nice diagram that we have.
Just to add to your point, I would personally feel that any of the immunomodulators that we use have only very specific points of action as to where we can use it in the point of the evolution of the disease. But during the process. But Sepsivac is something that we can use commonly at any spectrum. And the earlier we use it, it regulates all the levels of the regulation, so where we don't end up using any of the costlier drugs. And we minimize the hospital stay to such an extent that there is a significant cost-saving effect for the family. And along with that, there is also the major point is that we don't have to face the complications of, as we know, mucormycosis, tocilizumab, and all this immunosuppression. Right. So probably those things can come down a lot more by using this the drug called Sepsivac. Now,
agreed. But in other areas, I would still have to have more experience. As regards COVID, it definitely worked, but I'm yet to analyze my data.
Ajay sir, you want to add a point?
Yes, to add to this particular point, I just want to make a strong statement here. Probably Sepsivac can give a run to the cocktail also. Because the moment patient becomes symptomatic, and if you give a Sepsivac, you are probably would prevent him to go into the moderate and severe stage. Because what I have used it, I always use it when things are down the line. Probably all of you whose positive experience about Sepsivac is all about using it early. So till the time patient is asymptomatic, don't give. But the moment patient goes on of 1 liter of oxygen, the patient becomes a little breathless or dropping his oxygen on a walk test, use a Sepsivac. The whole key of a cocktail is use it early before the immune system start developing something together. So why not use a Sepsivac here? It's a cost effective, it's a safe, it actually gives you protection about in a COVID as well as secondary infections also. So it can actually be a better alternative than even a cocktail treatment. The moment patient goes symptomatic with a little hypoxia, use it on that particular day. Because as you say, it requires certain amount of time to kicking the immune system. So you have that much 24 hours to 48 hours to have that particular thing. You have a luxury of time there. Rather than when patient is already on a 15 liter of NRBM and then use a Sepsivac, then it won't get that particular time. So use it where the cocktail is used, frankly.
Sir, just to add, sir, as your experience, you were saying that the severe patients where you ended up using the drug and you felt that they weren't so effective. So actually, then for me, what I felt is when I use it much earlier, it has a significant effect in conversion of the patient to COVID negative also.
That's what I say. It has a phenomenal role. It's phenomenal in a prevention of disease as well as prevention of progression of the disease. That's why I say 5-star for a prevention of a COVID in all way.
And the amount of money saved by the family.
Absolutely. It's a 1,20,000 rupees cocktail. If you don't get a second person, then the whole vial is purchased by one person. It's a 1,20,000 rupees.
And the ICU stay and the other expenses.
Absolutely.
Thank you, sir. Sir, and so then along with that, sir, I'll just ask you a question to add to this point that we discussed. Sir, in an ICU patient, we know that usually it's not like our normal patients where we know what infection we're expecting next. But in a COVID patient, the secondary infections, do you feel that the secondary infection has a particular, because as we know, most of the patients are COVID negative by the time we reach the point of secondary infection. So at that secondary infection and the debilitated bad lung at that point, does this combination cause an issue with the recovery situation, or do you feel that the infection itself may be a major issue for the patient going back?
Should I tell you something true data of my own practice? Now I know what is international data. For me, out of 2,400 patients in last 14 months, personally seen by me and personally treated by me, we hardly had any secondary infection. We never had any even fungal infection which the whole world was worried about. Probably less of antibiotic. We are using very minimalistic treatment in the COVID. If I say to the India now, what we use in the COVID is 4 drugs, nothing more than 4 drugs. People get remdesivir, people get steroid, people get an LMWH, and people get bevacizumab in a second wave and tocilizumab in a first wave. Because in a second wave, we never received tocilizumab from a government because government took the whole stock and they wanted us to ask for it and never delivered on time. So we end up having bevacizumab. Other than these 4 drugs, we haven't used anything in a COVID in a second wave. And I don't know, should I say it or not, but probably 20 to 20% is the death rate of a COVID in a hospitalized patient in the second wave. We are still clogging somewhere around 3.2 or 3.4, which is significant. In fact, no antibiotic is basically working for us. Now, I'll share something. I was reading a lot of immunopathology in last 2.5 months because we all are clueless. We are always wanted to learn something about how this COVID and everything works. Now, there's a phenomenal. You always see that pediatricians always say don't give antibiotics to the viral infection. Now they say because it is a viral infection, don't give antibiotic because it is of no use. Now concept is they are not using it because it is of no use. I'll put a 180-degree paradigm shift to here. Don't use it because probably it will make harm. You know why? Because every antibiotic changes a gut flora. And gut flora is the main signal where the signal gets originated to the dendritic cell and macrophages in a lung that now there's a foreign intruder inside your respiratory system, go and engulf it. The moment you change the gut flora by using an antibiotic when it is not really needed as a defense or prophylactic antibiotic, you are allowing that gut flora to change. So the signals goes to the lung macrophages and dendritic tissues are sluggish. And because of that, your virus get time to multiply to the level which is at times become an uninhibited growth. So using the antibiotic when there is no direct evidence of infection, because we have this particular defense mechanism goes on into surgical cases also other than COVID. Let's treat with the cephalosporin prophylaxis. It's a spinal surgery, it's abdominal surgery. Let's give a prophylactic antibiotic. Now I'll quote certain data from an international scenario. Whenever people use cephalosporin it is well emphasized in a study that when cephalosporin-based prophylaxis given in a 2,641 consecutive patients who had undergone heart surgery for over 5 years, prolonged prophylaxis, and when they say prolonged prophylaxis, they say more than 48 hours is a prolonged prophylaxis. Compared to short-term prophylaxis is not encouraged and is not associated with decreased risk of secondary infection. On the other hand, it clearly associated with increased risk of colonization of MDR organisms. So don't use antibiotic if it is not evident that there is an infection there and there is a sepsis there. But yes, secondary infection is there on a rise. Approximately 15 to 20% patients who get admitted in ICU for some other reason, they acquire secondary infection in their ICU stay. 15 to 20%. And out of that, close to 40% goes into complication and death because of that. All these infections are basically broadly categorized into ventilator-associated pneumonia, intravascular catheter-associated bloodstream infection, catheter-associated urinary tract infection, and surgical site infection. So these are major 4 things where people acquire secondary infection which they are not come with when they reach to the ICU of a hospital.
Dr. Tony, just to apologize for interruption, there was a message from Dr. N.H. Krishna to quote some recently published study on prophylaxis. With a lot of discussion already happened. So just I will speak 2 lines. So there was data recently published on 3,000 plus patients for the prophylaxis use of Mycobacterium W. And here what is the efficacy, people who have not received vaccine has come to somewhere around 70%. That is one part. Also, people who have received Mycobacterium W and got COVID, the infections were mild. So there is a clear-cut demarcation which was observed that incidence of both symptomatic COVID-19 specific hospitalization, they found there were rapid and significant differences actually in the MW group versus non-MW. And so there was a trend towards MW mediated resistance to symptomatic COVID-19. And the only side effect was local adverse event found to close to 22 to 24%. That also healed over the time. So that is all. That was a message from Dr. N.H. Krishna. So I was getting the message. Sorry for interruption. Thank you so much.
Tony, Dr. Dixit, I just need to leave. So thank you very much. Yeah, I've got another commitment at 10 o'clock.
Thank you, sir, for your excellent presentation.
Thank you very much.
Okay. So
Dr. Tony, this was the slide that I was talking about. So we have all the inflammatory markers and the specific immunomodulators accordingly. And once everyone has seen, we can remove the slide and go ahead with our discussion. Thank you.
Madam, you can say a few words more if you want to, along with them.
Just if we focus on the lower aspect of the slide, we have all the inflammatory cytokines and how each and every immunomodulator would have. And that is how we have everyone using different spectrum, someone using IVIG, someone using corticosteroid, and depending on these, in fact, chloroquine, immunostatin, everything, and possibly the drugs that even I don't have with the experience with erituran and spinomate, these can also be used in future. Thank you.
Madam, this is really a beautiful slide. Everything is
just
covered.
Okay, thank you, sir.
Thank you.
You can stop sharing the slide. Thank you.
No problem. So I think I'll proceed to the next question. Dr. Varun.
Yeah.
Yeah. I would just like to know, in COVID-19, now since you are working in a good setup, you must have been already exposed to using most of the drug combinations for the immunosuppression purpose. So what did you feel as your clinical experience in the difference in the usage of between the tocilizumab, itolizumab, Sepsivac, and all the immunomodulator drugs?
Yeah, first of all, these IL-6 inhibitors, these monoclonal antibodies, they are more of immunosuppressants than immunomodulators. I think urinastatin and Sepsivac, they would be, classified better as an immunomodulator. So we see that, they don't really add up significantly to other infections that we see. Tocilizumab, itolizumab, and, even the newer oral agents like baricitinib and tofacitinib, along with steroids, they have only one major problem. We would love to use them if they were not having, secondary septicemia as the major complication because of them. So we have used them. They are in the guidelines. And honestly, high dose steroids, pulse dose steroid. I mean, we have used steroids in all form of, administrative indications. And yes, IL-6 inhibitors at the same time, when given at the right time, they would give good results. Honestly say, they could give good results. But then what happens later on is, sometimes even when the patient has been shifted to the ward from ICU after recovering, and, sometimes after 5th, 6th day, they would, start developing leukocytosis, band forms, toxic granulations. And that is when we start pitching in with higher antibiotics and, maybe antifungals. That is when the situation starts to, look bad. So maybe the mortality data that we look at, which is presented wherever it is usually, initial 2-3 days data. If we look at, 7 days or maybe 28 days mortality, I feel strongly that, once the data is out, we will see that tocilizumab and all these IL-6 inhibitors, they really did not make much of a difference, because eventually the patients would have died of some other, aggressive secondary acquired, hospital-acquired infections. Whereas if we are talking of, urinastatin, I have not used urinastatin much in, these COVID patients. But yes, whenever the shock is not responding to anything, like we've put in steroids as well and everything you've done. Sepsivac I haven't used in shock state. So urinastatin is the only thing that usually comes to mind, that, this okay, we use it. But I again don't know how much it helps, because you are using it in a frenzy at a situation when it may or may not work. Sepsivac at the same time is we can see it standing different, because Sepsivac you can give it even when the patient has walked in the hospital. Urinastatin you will not give, not the other immunomodulators. If the patient is not hypoxic, you will not even use steroids in those patients. So I think all of them cannot be clubbed together, because all of them have a different, mechanism of action, the timing of their administration, and honestly the outcomes as well. Steroids are being implicated in this, mucormycosis. Honestly, I feel that in first wave we use more steroids than the second wave. In second wave, immediately after 2-3 weeks, black fungus was all over the media, and people were asking, "Oh, are you using double dose of steroid?" So maybe we were pushed to the back foot, not using steroids in the second wave. Maybe outpatient clinicians might have used steroids more, but then indoor patients we have used steroids lesser than what we used in the first wave. But then we did not see mucormycosis as much as them. So I think all of them are differently placed, and their administration and indications would also be different. So they cannot be compared, all of them together.
Do you feel any specific difference as to where you have felt a better action in using a particular thing earlier or later, like that?
Say again, I could not. Yes.
Did you feel during the course of treatment of different patients, any particular one of the particular category drugs work better at a certain point of time during the duration of the disease?
Yeah, that I would say tocilizumab and baricitinib. These are two drugs which, when given right at the time, they like bingo. They are like spot on, and if you are using them rightly, and at the right time, I think the results are amazing as far as 2-3 days are concerned. Baricitinib can have a longer lasting effect, because you continue giving it for like until the patient stays in the hospital. Tocilizumab is like one shot of arrow that you have shot at, at the time of desperation. And many patients, they come out well, but then some patients who are ILD, COPD, already harboring some, colonized with all sort of bacteria. These patients, when you give Tosi, they don't have very good result because later on they develop secondary infections for sure.
Thank you. Dr. Shashi, sir. Sir, since Ajay sir and me and we all have different point of views where we use Sepsivac, but just in general, and do you feel there is an ideal stage in COVID where we put in the onset of an immunomodulatory molecule?
In COVID, you're asking?
Yes, in COVID.
Yeah, that's what. Our guidelines, actually, we have put it in the severe, but what I told in the earlier, it is better that we start using as early as possible. The saturation falling between 90 to 94. So that is the time when we should start initiating the use of Sepsivac. So that is my take on that.
And so I just, actually we're having a bit of a time crisis. I think that taking the time. So I'll just take a question as to what are the comments on role of prophylaxis of COVID-19 and prevention of ICU infections, particularly nosocomial infections, and is there a role for Sepsivac in that? And I would just say in simple that yes, definitely it definitely has a role in probably preventing worsening infections with the exceptional work in stimulating the innate immunity and improving the macrophage action. We also will probably help in the viral low reducing, along with probably it also helps the immunity build up against bacterial infections also, and doesn't allow further worsening of the patient. So I think an early at least mild to moderate level of disease. But the issue is in the healthcare workers or high exposure staff, probably prophylaxis also has a good enough role. Like most of the doctors of CCI have felt. For example, I've not fallen sick in more than a year now due to anything after I've taken the prophylaxis. So that's why it also helps in working manpower hours. It doesn't let you take a leave or fall sick. So overall, I think prophylaxis also helps at least in the high exposure people rather than just in general public. So actually, we have a few questions on relation to TB also. Since we're having a time issue, I think we'll just take a few questions out of those just to clear any doubts. So, Ajay sir, can I ask you one question? Yeah, sir, what are the current challenges with respect to TB management, which you definitely face in your practice, and from your practice? And do you feel that, for example, we know there are certain studies even show that Sepsivac may help in the overall conversion rates or improvement rates of even maybe MDR, XDR patients. Any opinion of yours that how do you feel may help in TB in general?
We all know that we have a lot of clinical problems in tuberculosis management. Few are at a patient level, few are at our level, few are at an administrative level. One is delayed diagnosis. Second is most people use improper dosages. Third, there's a default on a patient's head. Fourth, it could be major problem of a resistant TB, MDR TB and XDR TB. Fifth could be toxicity of drugs because of a prolonged treatment of a drug-resistant tuberculosis. There's a HIV-TB co-infection, which is a major issue here. And there's a recurrent TB, another issue. Person has been treated, but again required tuberculosis in a few years. And still death of a tuberculosis is a major hurdle here. They always say 2 deaths in 3 minutes is still a government statistics, which is a huge. Now, regarding your second part of the question, whether MW can be used as a prophylaxis as well as treatment adjuvant for a tuberculosis treatment. We already have a good study in India. ICMR has conducted a good study with 28,948 people belonging to 272 villages in Kanpur. They observed these particular people for 13 years, 1-3. They were given 2 dosages of MW, so-called vaccine, with 6 months apart. None of them developed tuberculosis. This is because this MW shares its antigenic determinants with the M tuberculosis as well as M leprae. Now this is about prophylaxis, and this is not a one study. There are so many studies. If you see PubMed, there are so many studies which will actually say the same thing, that MW has a phenomenal prophylactic effect in preventing tuberculosis. That's one thing. Second thing, adjuvant for a therapy. Now there is something called, you always give a MW along with the anti-tuberculosis medication, and there's an early sputum conversion, and the gap between control group and MW group is whooping 30 days. 30 days before the control group, there's a sputum conversion in MW group, again Indian study. Now there's another non-tuberculous mycobacteria which is used worldwide called Mycobacterium vaccae, VACCAE, vaccae. Now this particular used is HIV co-infection, HIV tuberculosis co-infection with a phenomenal success rate. So basically all these non-tuberculous mycobacteria, which are saprophytic, which comes from a soil, which are non-pathogenic, which are cultivable in a lab, have a tremendous scope in preventing a tuberculosis as well as managing tuberculosis, including resistant as well as HIV co-infection effectively along with AKT.
So that as we know, TB is one of the most disastrous diseases in which our country is facing and our population is facing. This study which you have told now will probably play a very different role in the people who are concerned with handling our TB protocols and even for the MDR and XDR regimens. So that will probably help a lot of the patients too.
Every hospital on this planet, in this country, which is worth its salt, Gangarao Hospital, AIMS Hospital, Hinduja Hospital, ICMR, Medanta Medicity, every hospital was a part of this particular study.
So that will change the treatment of TB in India, that means. Definitely. So I think since it's getting a bit late and it's Saturday night, people are having certain appointments to get to. And so I would be so happy with this wonderful panel discussion with all our extremely esteemed, exemplary participants have given their wonderful opinions. And it's just that I would like to get a few, just a concluding statement per speaker as a take-home message for the vast audience who may be watching this talk. And I just want to put it out that no one should feel that Sepsivac is a miracle drug. It is not a one-stop solution for COVID. It is an adjunct to the treatment lines that we are seeing and handling in this country. And but definitely, probably the one thing which I can just think about is that even in most of the Western countries where all these drugs of tocilizumab and everything has been used here and there and everywhere, nowhere Sepsivac has been used. The Sepsivac is at least as our Indian potential for generating new research and new working molecules for saving the world. I would strongly say that probably lots and lots of lives have been saved in India based on the Sepsivac usage, which probably all the practicing just physicians have already used. And now I hope we can spread this message to the world, where we can save lives all over the world by using this molecule. And I hope people take note, other organizations take note of this product. And so just as a conclusion, I would like our esteemed speakers, and I will take the last talk. I will just ask each of our speakers, Dr. Amritsar, could you please give your esteemed idea as to how you would like to see the usage of COVID-19 treatments and Sepsivac along with that.
Dr. Shashi.
I would like to add one thing, if you allow.
Please do, Dr. Eema.
Shall I? Yeah, shall I? So there's one request to all the fraternity with due regards and apologies if it offends in any way. I know, and we all know that after taking Sepsivac after the first wave, we have been less afraid in the second wave, though the second wave was most disastrous. But my serious recommendation is please don't leave using the PPE, because seeing you all are idols for the next coming residents or next upcoming pulmonologists. They are trying to follow you. They are not knowing whether you have used the Sepsivac or not, or whether there is any wonder drug or not. Please don't give a wrong message to the youngsters. They are getting predisposed to COVID. They are getting affected. And if we lose any one of our medical fraternity, whether it be the medicos or the nursing staff, it would be a huge guilt on us. So please use your protective equipments.
Madam, truthfully,
thank you.
More than 1 year now, I also not used PPE in the full set. I only use proper gloves, proper protection, and a good double mask, 295 I wear for going in COVID zone. But the problem is because we have other areas also to cover, we cannot be, it's so difficult to get in and get out of a PT. And
I understand, sir. With this humid and temperature things, it's all the more difficult. Or either you guide your people how to use double gloves, wash hands. Please then make a special effort to teach your youngsters regarding this.
Madam, do you mind if we give all your colleagues Sepsivac, the prophylactic dose to keep them safe?
I have given. Nothing
to fear them, madam.
I've definitely given to all our staff. Yeah. Okay. Thank you.
Thank you, Shashi sir.
One take-home message. What I would like to say is when it comes to Sepsivac or MW, basically it can potentiate the activation of the dendritic cells. So the idea of giving intradermal is to develop the dendritic cells, thereby the TLR, what Dr. Subhal was talking about, the TLR receptor agonist are stimulated, which further helps in scrubbing of the both. It could be a viral infection or a bacterial infection. That's the message. They should know that how it basically, in one word, you want me to tell in one word, this is a simple mechanism of how it helps.
Absolutely, sir. Absolutely. And also along with that, that's what. So overall itself, the benefits should be more compared to what we use in the spectrum. Thank you, sir. And Ajay, sir, so you want to add any closing comments, sir?
Not really. Nice program, Tony. You did your job well.
No,
probably we are in a time constraint. Let's wind up now.
Yes, sir.
Thank you.
I would like to thank our CCI committee. I would like to thank especially Dr. Krishna sir, Narayana Pradeepa, our core committee members, Dr. Vijay Chanamchiti, our webinar mastermind who runs everything. And I would like to also thank the CADILA, the team who are so strongly confident in the molecule that they expect to save lives, that they have, as far as I know, they have given to their entire office staff population in their main branch, and almost no one has actually got COVID, though they're not a direct exposure, but from the public exposures. Nobody has actually gotten COVID, probably not even a mild disease level. And along with that, what our healthcare workers, who we know that the more doctors that we lose, the more lesser manpower we have for managing the crisis that our country is facing. And now probably the safest way to protect our health workers is probably giving a prophylaxis dose, at least to people who know, who you know, who we know, who we can protect, and not as a part of any national attempt to vaccinate the entire country, but at least who we know, who we can protect, we should keep them safe. And continue to do our work in this war against the virus. So thank you to this CADILA team for continuing your excellent activities. And please do help us with getting us the research data so we can prove and give it to more and more people. And only the issues that we should, everyone should be aware that pregnant ladies, breastfeeding children are categories that who we try to avoid giving Sepsivac to, because we don't know how it will act on the immune system in those developing situations. Otherwise, every other person should be safe, and particularly elderly, very elderly also try to avoid. But if you're trying to save a patient's life, there is nothing else to give. We can always try. That is the only thing we can do at that point. And above all, God should help all of us.
Thank you so much, sir.
Thank you.
So, thank you all the faculties. Thank you CCI for giving CADILA opportunity. Definitely CADILA is always known for affordable innovation. That was the slogan for our founding member, and MW is one of such example. Looking forward for the collaboration to generate more data to serve the mankind through with the help of all of you. Thank you so much. Thank you all the faculty members. Thank you CCI. Thank you, sir. Good night.
Thank you.